keeping up, these webinars and the international webinars, inviting the international people to improve the education here and at the hospital, and for us as the junior staff for him. We are introducing Professor Michael McKee, who's a full professor from Arizona, and actually Professor McKee, he's the man of proximity. He was in Toronto, at the University of Toronto. There, he was the program director there, and I was one of the fellows who was trained with Professor McKee. And there were a lot of people. They were under his training. They were inside. They are Saudis, and they were under his training. Now, Professor McKee, he's working at the University of Arizona. He's head of the department there in Phoenix, Arizona, in the United States. So welcome, Professor McKee, and you can go ahead, please. Go ahead, Prof.
Great. Well, thank you very much, Sati. It's certainly my pleasure to be able to speak with everyone there today, and I'm very hopeful that I'll be able to answer some of your questions about this difficult fracture, and hope that my talk will help you to maximize the success you have when you deal with proximal humeral fractures. And most of the talk will be about fracture fixation, but I am going to talk a little bit about arthroplasty at the end. Are my slides advancing okay there? Does that look good?
Yeah.
Yes.
Okay, great.
Yeah.
So I do have some disclosures. This is my disclosure site in the American Academy of Orthopedic Surgeons, which is up to date. And I do have a disclosure, and I do have a financial interest in one of the plates that I'm going to discuss, and I'll talk a bit about that. And I've previously been to Saudi in 2009 with Dr. Sati, and he was an extremely good host. And I was very much hoping to be able to go back there this fall in November, but of course, COVID changed all of our plans. So unfortunately, I can't be there in person, which I was really looking forward to because I had such a good time last time, but I will do my best to give you this talk virtually. So I think this case demonstrates the difficulty we have in dealing with this kind of fracture. So this is a 78-year-old female patient of mine. She was retired, very pleasant lady, lived by herself, and she had a number of stable medical conditions. And I saw her in the clinic with this acute fracture, and she said, you know, what do I need for treatment? And I think this case illustrates the fact that we really don't know what is best for this patient. The two main options for someone like this would be to use a locking plate and fix the fracture anatomically so that it is in a good position, and hope that it heals and theoretically improve the patient's outcome by doing that, or to treat it non-operatively in a sling and see what happens. And we know that neither treatment's perfect, so we look to the literature to see if there's any topics or any literature on this specific topic. There are actually 3 randomized trials that look specifically at that kind of fracture in older patients treated either with a sling or with surgery. And surprisingly, there is no difference in outcome with the currently available locking plates comparing surgery versus no surgery for this particular fracture. And that can be hard to understand when we look at our plates and we think they would do a good job of reducing the fracture, and yet really we can't show much benefit for these patients. And if you look at some of these studies, these are all randomized trials looking at surgery versus no surgery. The one thing I'll point out is that all of these trials show the results in both groups aren't very good. So it's not a situation where both groups do relatively well, both groups do equally poorly. And we can't really show much of improvement with the conventional plates that we have right now. There's also an interesting study from a New York database published in 2011, looking at the trends in variations in treatment. And this looked at over 100,000 fractures around this time and noticed that the incidence of the fracture was the same, but the rate of operative intervention increased by 25%. So it was clear that the rate of intervention on doctors' parts was increasing, and we were operating on more fractures. But what they found was that in the later years of the study, in 2005, the reoperation rate went up 50%. And this was interesting because it was comparing it to a time in the year 2000 or so when we used older plates. And what they found was the reoperation rate with the newer plates was going up, not down. So if you look at 1999 or 2000, most of us would use some kind of cloverleaf plate or some variation on the cloverleaf plate in order to fix these fractures you see here on the left. In New York, when they switched to the locking plate by 2005, and it was a fairly complete switch, and there's sales data to support that, what they found was the reoperation rate within a year did not go down, but actually went up. So the one comparative study that we have looking at the old style plates versus the new style plates shows that the locking plates really performed poorly and had a higher reoperation rate in this kind of setting, which is of course something that you don't want. And I have seen a large number of complications with proximal humeral locking plates, and even the most modern series with the most recently available plates in good hands shows that there's a high complication rate. And for example, those 3 studies that I talked to you about all had significant complications rate. And all of those studies only accepted surgeons in the study who had done 50 or more cases. So it's not as if they were novice surgeons or hadn't done it before. They've all done 50 cases. And even then, they still had a high complication rate with their plates. And these are some of the examples of cases that didn't go very well. At the American Academy in 2019, I gave a seminar on proximal humeral locking plates, and I asked the audience, and we had an audience response system, so the audience could respond to the questions. What issues and problems do you have with the current proximal humeral locking plate you're using? And these are what the audience members said. And there was about 200 people in the audience, so it was a fairly well-attended seminar. Tuberosity fixation was a major issue. Over half said they could not fix tuberosities well. Screw penetration and loss of reduction and other things. So basically, not being able to fix the tuberosity and losing reduction were the 2 major concerns in 2019 that the surgeons talked about. I was going to ask the same question in 2020, but of course, COVID caused cancellation of the meeting, so we couldn't do that. So here's a case of mine. If you look at this case here, there's a separate tuberosity fragment in this case. And I've tried to put the plate significantly higher than I usually would for the sole purpose of capturing that tuberosity. In addition, as we all do, I put sutures through the greater tuberosity into the rotator cuff to tie the rotator cuff down to the tuberosity to prevent any displacement. So with the conventional plates available, in this case, I did everything I could to avoid tuberosity escape. And despite that, you can see what happened here because there's tremendous pull on that fragment by a relatively small, on a relatively small piece of bone by a large rotator cuff. And so tuberosity escape, even when you try and do the conventional things to prevent it from happening, such as suturing the rotator cuff down and trying to put the plate higher to fix it, that still happens to a lot of people. This is a pictorial from Pascal Boileau, who's a famous French shoulder surgeon. And what this shows is that with the standard plates we have, seen in blue, we don't fix the tuberosities well in 3- and 4-part fractures. And you can see in the cross section here, the tuberosities get pulled in. Those are the red arrows. And the plate sits laterally and does not capture the tuberosities. And this is a slide I borrowed from him with his permission to show this clearly. He's designed a type of locking nail with specific screws for the tuberosities, which is one way to deal with this issue. The main problem is that there's a tremendous varus pull from the rotator cuff where it attaches to that greater tuberosity fragment. You can see here how this pictorial says, well, you can try and eliminate that by sewing the rotator cuff down to the screws in the plate or to the plate itself and take away from this deforming force. The problem is it simply doesn't work. There are two separate studies in the literature, and I show you this most recent one saying, okay, if you have a biomechanical model of a 3 or 4 part fracture and you suture the rotator cuff down to the plate, what difference does it make to the stability of the fracture? And both of these studies clearly showed, and I quote, tension relieving rotator cuff sutures do not increase the stability of the repair of these fractures. And there's no mechanical data to demonstrate a benefit to adding suture to this construct. And there's two separate studies like this that show what we conventionally do does not routinely work biomechanically and does not seem to work consistently clinically. This is a great study from a German group from the University of Heidelberg, and they looked at 98 patients. So this is a 2019 study by a very well-recognized group of surgeons who had all done a lot of cases, and they looked at 100 patients. And what they found was that the complication rate in their hands was 32%, and 27% of patients required revision surgery. I would argue nowhere else in fracture care would we see or accept this high a rate of complications. Femoral shaft fractures lower, ankle fractures lower, forearm fractures lower. Only in proximal humeral fractures do we seem to have this very high complication rate. And what they noticed was that if the greater tuberosity pulled off, or cranialized as they called it, or there was significant residual displacement, then all of these things resulted in a bad outcome. So tuberosity pull off and residual displacement resulted in bad outcome. And this is a modern series of good surgeons with the modern plates. We still have a major failure rate here that is unacceptable in this setting. What they found, again, just to reinforce it, was in 25% of the cases, they had GT fixation loss and migration, and it was a very, very major risk factor for poor outcome. So the relative risk of a poor outcome tripled if you had your greater tuberosity pulled off, which we all know, because if the cuff pulls off the tuberosity and it's stuck up over the top of the head, we know biomechanically this is very, very disadvantageous for the shoulder. And this is just an example of what happens here as well, especially if you don't have any support on the calcar. So what do we do to make that better? Well, a number of people have come up with a number of ideas about how to fix tuberosities better. And this is an example of so-called stacking a plate, where you take a small plate and curve it and cut it and put it underneath a regular plate as a way of capturing a tuberosity fragment. And obviously this is something which is done intraoperatively with just fashioning the plate when you get there. This is another example of being able to capture tuberosity with a mesh plate. So other people have designed mesh type plates that hold the tuberosity down, although these can be bulky and certainly are not very soft tissue friendly because they take up a lot of space on the surface of the bone. Acumed, which is a company that has thought that this is an issue as well, has developed a plate with a special flange, so you can capture the greater tuberosity with the flange on the plate as a way of improving stability. And I've always used in my own practice a cloverleaf type plate. And this is a patient who came to me late, around 6 or 8 weeks after the fracture. And you can see how the greater tuberosity is completely superior here, sitting on top of the humeral head. The entire shoulder is sagged down because it doesn't have that pull of the tuberosity. In the past, I've used a cloverleaf type plate to capture that tuberosity down and hold it in place. It's true, you do risk some risk of impingement, but I would argue that it's much better to have a tuberosity and rotator cuff healed in the proper position and then come back and take the plate out if it impinges. If you don't have the tuberosity healed in the proper position, it's a very difficult reconstructive operation. So this is something that I did in the past when I wanted to fix a tuberosity. This is another example intraoperatively, a complex fracture in a relatively young person. You can see how it's fixed. And then there's a separate plate applied to hold that specific tuberosity down with a tine or spikes to hold it there. And this isn't anything new. This is something that we've done in the hip for a long time. And the introduction of these trochanteric plates with spikes on as their superior surface to hold trochanteric fragments in place has been extremely successful in the hip. And this is really an identical situation where you have a small fragment of bone, be it the trochanter or the greater tuberosity, with a large muscle pull in varus affecting that piece of bone. And these kind of hook plates in the trochanter really have revolutionized the care of these fractures and made it much more clinically successful in this setting. So we thought, well, if it works so well in the hip, why not design a plate like that? These are some initial artist drawings of a plate that we designed. So I do have, by way of disclosure, a financial interest in this plate. But if you see here, we designed a plate that had flanges anteriorly and posteriorly, and also superiorly enabled us to obtain fixation in tuberosity fragments, be it lesser or greater posteriorly or greater superiorly. And the plate comes in a variety of different sizes and flange patterns in order to save the tuberosity fragment from displacement. This is an example of the plates. They're made by a company called ITS, which is based in Austria. And there's a number of different plate types. We've incorporated all of the things in the plate that we know work conventionally. We have locking capability if you need locking screws. We have positions in the plate for calcar screws, and we also know that calcar screws are very important. And additionally, we have different lengths to go down the shaft depending on the length of diaphyseal extension of your fracture. But lastly, in different from other places, we have flanges, and these flanges are contourable. So once you put the plate in, you can contour the flanges in order to get better fixation or purchase of the humeral head. And so we felt this was a very good way of capturing some of these more complex fracture fragments and potentially improving outcome. And the flanges are narrower than the main body of the plate because they don't need to be thick and they just need to be contourable to hold fragments of bone. And as I mentioned, they come in a variety of styles and lengths depending on what kind of fracture fragments you have to deal with. We also wanted to be sure that this idea actually works. So we did a biomechanical study looking specifically at the purchase strength of these plates on the greater tuberosity. And so as we know from previous studies that fixing the tuberosities with suture doesn't work, we wanted to know if fixing it with a hook type plate made a difference or not. And this is a study that we did here at the university with a number of the residents, Dr. Robert Walker, and Paulo Castaneda and Joe Goodwin. Basically, the study was very simple. We made a three-part fracture that included a large greater tuberosity fragment, and we applied the ITS hook plate, as we call it, the Phoenix plate on the left, versus a standard proximal humeral locking plate that you see in the middle. And these are representative radiographs of the two experimental setups. So you see the main difference in this particular model is the hook on top of the Phoenix plate to hold the greater tuberosity in place. And we measured displacement with a number of radiographic parameters and balls that you can see isolated here. And this is a model, or this is a pictorial of our experimental model. In addition, just to be as clinically relevant as possible, we also included a suture technique to fix the tuberosities back down on both specimens in identical fashion, just as you would do clinically according to standard of care in 2020. We got a lot of information from this study, so I'll just show you one most representative slide. The regular proximal humeral locking plate is in gray, and the ITS or the Phoenix plate with the flanges is in red. And you can see, and these are specimens that we tested left and right from the same specimen so as to get away from any potential complications with different sizes or different bone densities. And we randomized which left or right we use for each one. So these are matched or paired specimens in a randomized fashion. And you can see that the strength of the ITS plate for pull-off of the tuberosity is over 500 newtons, whereas it's only 220 for the regular plate. So the ITS plate is more than twice as strong as holding the tuberosity in place as a regular plate, which makes sense and also reinforces our clinical supposition that this would be the case. And so there is some good biomechanical data to support the theoretical benefits of having the hook in place. So, well, does it work clinically? We're now in the process of conducting a pilot study, so we can't really conduct a comparative or prospective trial until we have conducted a pilot study in a number of individuals to see if the plate has any unknown recognized complications. And remember, impingement is still a concern with the plate in this position. And I'll show you a few representative cases here. This is a relatively young lady who fell off a horse, and she has a badly displaced two-part surgical neck fracture, which you can see in the radiograph on the left and the picture on your right. And I show this as a video. Unfortunately, I don't think it'll work today, but if you look at this pictorial here, you can see that with one screw above and one screw below, and you can also contour the flanges of the plate. So there's a special instrument which you can put on the plate once it's in situ, and you can contour or crimp the anterior and posterior flanges down. And this alone is enough in this patient to make the fracture completely stable. So typically when you're fixing a proximal humeral fracture of this type, you would not want to move the arm until you had all the screws in place. But in this agreeably simple fracture, one screw up and one screw down made it a very stable construct. And you can see that it was very, very effective at helping reduction. Also, in this particular case, there's not a large greater tuberosity piece, so we don't need the actual plate with the hook that goes over the top. We can use a plate that stops shy of the tuberosity to minimize the potential for any impingement. So this plate does not have the hooks up top in this particular setting. And there's the final radiograph. You can see that the plate stops just shy of the tuberosity, so that impingement should not be an issue. We have the calcar screws, and I'll talk a little bit about calcar screws. That screw is very important to reduce the risk of varus collapse. So there's a couple of good studies, including the first one, probably by Mike Gardner, that shows that if you place that screw within a centimeter of the calcar, the subsequent risk of mechanical failure and collapse is much lower. So this plate also uses all of the conventional aspects of fracture care for the proximal humerus, locking capability, calcar screws, etc., that we know work. And additionally, it has these flanges. You'll see that this plate is put on through a deltopectoral approach, and people often ask, well, how do you get the screws in the most posterior flange? You can see here, if you rotate the arm internally, once you have provisional fixation, it is usually fairly straightforward to obtain screw purchase in the posterior flange in this setting. It's also possible to use this plate in a deltoid split type approach, which we having done that as well. And we can talk maybe in the question and answer session about how to do that. We can fix it using either approach. What about a more difficult salvage situation? This is a lady who comes 8 weeks following the fixation, following the fracture of the proximal humerus here. You can see that she has a delayed union. She has lots of pain, and significantly, she has bad varus. So most of these fractures, if they don't heal properly, they tend to have significant varus deformity. And that is something that you can see in these cases. And this is certainly one of these cases as well. So it's a tough situation to try and restore the alignment and get that patient out of varus, because the rotator cuff will continually pull ahead into varus given the opportunity to do so. So this is a situation where we would use the plate with the superior flange so that we get a screw and the two hooks into the greater tuberosity to give us better fixation. That's a major advantage in this plate device. Here's that patient intraoperatively. You can see how the proximal hook holds the tuberosity down and helps correct the varus deformity. We also have calcar screws in, and you can see how the anterior and posterior flanges help cradle or hold the humeral head over the shaft. And that's one nice aspect of this plate, is that if the humeral head is in the middle of the flanges, then the shaft has to line up with the shaft of the plate. And that's a very helpful thing intraoperatively. This patient at 2 weeks postoperatively, and we had sufficient stability to allow them to begin early motion at that point. I thought I'd show you a couple of other quick cases here. This is a 63-year-old female with a more complex fracture. You can see that this is a valgus impacted fracture. So significant valgus orientation of the humeral head. The medial hinge here is still well maintained. So we're hopeful that if we're careful with this type of fracture, we can hinge it up, maintain the medial hinge, and not have avascular necrosis or any other problem. And you can see here that the tuberosity is significantly overriding this. So when you fix this, there may be an issue with tuberosity displacement if you're not careful. These are some intraoperative radiographs, and you can see the degree of comminution that exists here. And there is a K-wire, temporary K-wire fixation. And then we use the plate to hold these fragments into place and fix it there. And I think that intraoperatively, K-wiring the various fracture fragments together is, of course, a standard and excellent way of getting a reduction prior to plate fixation. This is the definitive aspect of the plate. We felt that tuberosity fragment was sufficiently big that we could capture it with the regular plate with the superior flange without having to risk impingement from the hooks. And then you can see also here we've placed a calcar screw, which is critically important to reduce that varus collapse. This is this patient only about 6 weeks postoperatively, and you can see that she's got great motion for 6 weeks. You can also see that if you go back one of the significant considerations is the concern about a potential impingement of one of the flanges. And we put the flanges right to the edge of the articular surface, but they don't go past it. And so we don't really see much impingement in the internal and external rotation planes. And I'll show you another case like that in a minute. And this lady also did not have much in the way of impingement. So we had sufficient stability to allow early motion, which enhanced her functional outcome. Here's another patient with a very large impacted valgus fracture with a very large DT fragment. You can see in the red arrow here how big that is. If you left this fracture alone, I think we would all agree that it would probably heal because it's an impacted metaphyseal fracture, but you would have a significant mechanical problem in the shoulder because of the overriding of the greater tuberosity relative to the head. So this arm would probably heal, but it would be one that impinged relatively quickly, would not have much in the way of overhead motion, and would have a lot of weakness and pain, in my opinion. For this patient, we did feel that fragment was large enough to warrant having a hook placement. So you can see here, this is the intraoperative radiograph showing the flanges fixing the tuberosities and the hook in the GT. And then also we have the calcar screw. At 8 weeks, this patient had union of his fracture, had union of the greater tuberosity, and had over 120 degrees of flexion. I'll show you an interesting case now of a fracture dislocation. So this is a patient who was mountain biking and had a bad fracture dislocation, also had an axillary nerve injury with a biceps tendon laceration, otherwise completely healthy. So you can see the radiographs here. This is quite a complex fracture. There's a large head fragment. Now we know from Ralph Hertel's work that if you look at a fracture like this, the rate of AVN of the humeral head is actually quite low because there's a long medial hinge or metaphyseal spike that has a lot of blood supply attached to it, a lot of soft tissue attached to it. So your goal as the operating surgeon is to maintain that degree of soft tissue attachment and to not strip off anything here on the medial side. So the head fragment should stay alive here as long as you don't strip it too much. Secondly, there's a large DT fragment here, and that's going to be something that you'll really need in this patient, especially since at the present time, their axillary nerve isn't working and they have deltoid paralysis. So they're going to be extremely dependent on the greater tuberosity in this kind of setting to get any kind of shoulder motion going. These are intraoperative radiographs, and we've reduced this fracture, the large metaphyseal speck, and we've reduced the humeral head. And you can see how we've cradled, again, the fragments in the proximal plate, and you can see that we have the hook in that large greater tuberosity fragment. In this patient, I'd be very concerned about GT displacement using a regular locking plate, whereas this plate, I think, gives you very good purchase. You can see him now just a few weeks later. The fracture looks good, but you'll notice the humeral head is starting to have some inferior pseudosubluxation. This was a result of the axillary nerve palsy and the deltoid muscle not working well. And so we see often this kind of sag most of the time because of deltoid atony. This case may have been a bit more severe than usual because the deltoid was completely atonic from paralysis. And in this situation, usually we try and institute early motion and wait for the deltoid to return to function, which it usually, not always, but usually does. And one of the benefits of this plate is that we have enough fixation and things are solid enough that we can allow early motion. And here's this patient about 6 months later. They do have good restoration of deltoid function. You can see that they have very nice healing of the fracture with no evidence of avascular necrosis. This is a picture of the patient himself, and you can see good function. The thing that I want to point out is on the right-hand side of your screen, you can see that there's no impingement with internal or external rotation. And if I go back one, that's of concern. If you look at the slide here, you can see there's flanges front and back, but they don't go on to the articular surface of the bone. They do not usually cause any impingement. And so in this active individual here, you can see how they have good internal and symmetric external rotation so that they don't have to worry about that. This patient still had some residual weakness of the deltoid, but it was improving rapidly, and we anticipate a full recovery. I'm going to talk about periprosthetic fractures a little bit in the setting of this. We certainly in North America are seeing a dramatic increase in the number of prostheses being placed for various arthritic conditions of the shoulder, especially reverse prostheses, which I'll talk about as a treatment for fractures in of themselves. The epidemic of these fractures is seen because of the increase in the number of these prostheses that we're placing. So I thought I'd show you an interesting upper extremity periprosthetic case in which this plate's also quite useful. This is a 58-year-old female who had a reverse, short stem reverse done about a year ago, was doing quite well, was very happy with her shoulder prior to a fall. She fell from a standing height, and it was an isolated injury. So you see, these are her radiographs here, and you can see that she has a fairly well-placed short stem prosthesis, and you can see the reverse base plate up here. So the options for her would be either to leave it alone, and most of these periprosthetic fractures with displacement, and this is completely displaced, tend to take a long, long time to heal if they heal at all. So in most of them, we tend to intervene operatively. You can see that the surgical options would include removing this prosthesis and changing it to a long stem or trying to fix the fracture where it is. So this particular stem has a very proximal coat for bone ingrowth, and it was solidly grown. And you can imagine trying to take this prosthesis out, you'd probably have to at least split or destroy the proximal humerus to do so. And since her function was so good when it was in, we felt it'd be optimal to leave this well-fixed and seated prosthesis in place, and then if possible, fix around it. Some of the things to consider when you're seeing a fracture like this is the humeral stem solid, and we felt it was. Is there any sign of infection? There wasn't any sign of infection here. We're pretty positive that was not the case. And you have often to deal with poor proximal bone stock. And you can see that a conventional plate would not leave you a lot of space to put screws or fixation proximally, which might impair your ability to provide early motion. If at all possible, you would like to have some early motion here. to get this patient's functional recovery maximum. So here's an intraoperative radiograph, and you can see we have fracture reduction forceps distally. We've reduced the main fracture line intraoperatively. The stem was very solid as we anticipated and was not loose. And we would have had to do a major excavation of the proximal humerus to get the stem out. So it reinforced our decision to leave the stem in place and fix around it. And you can see we fixed it with a clamp distally, and then we provisionally placed the plate proximally. You can see again how advantageous this is going to be, because you can use the flanges to hold that proximal piece in place and also obtain screw purchase around the stem of the prosthesis. And you can see that picture here. This is a definitive radiograph following fixation of the fracture. And you can see how we've got a nice fixation of the fracture and multiple lag screws around the proximal portion of the prosthesis, and excellent stability. And we're able to apply non-locking screws to bring the plate down to the bone initially, followed shortly thereafter with locking screws that enhanced our fixation proximally. So we felt this was an ideal way of treating this problem, preserving bone stock, preserving the tuberosity attachment proximally, minimizing the magnitude of the operation. And we've done a number of these fractures in this way now, all with the same plate to good effect. And you can see these intraoperative radiographs show we've actually contoured the flanges to embrace and stabilize the proximal fragments very well. So that's kind of a good introduction to arthroplasty in 2020. Or in 2020. So I've spoken a lot about fixation of these fractures. I think it would be appropriate to talk a little bit about arthroplasty in 2020, because it is certainly becoming a very, very popular technique in the shoulder. And we see situations where we have to fix paraprosthetic fractures, and also when do we use the prosthesis primarily in fracture fixation. So here's a patient who comes in relatively active and has a bad 4-part fracture dislocation of her shoulder. And if you remember, we spoke about the Hurtle's criteria. You can see this head segment here is one that's unlikely to survive and has a high risk of AVN. There's no medial hinge. There's wide displacement of the head. The fracture is right at the articular surface and very high. You can reasonably anticipate that this fractured head is not going to survive, and there's a high rate of avascular necrosis. So on my hands, this would be a fracture that would benefit from replacement rather than fixation. Even if you did an excellent job of fixing this fracture, there would be a high rate of subsequent avascular necrosis, and we don't want that to happen. This is an intraoperative picture, and this was a patient who was subsequently referred to me, and I'll show you why in a second. So this is a hemiarthroplasty, which until recently has been the standard of care for this patient. And the humeral head has been replaced, and there's a stem down the shaft. And you can see that the tuberosity has been nicely repaired and reconstructed around the humeral component. And the hemiarthroplasty is critically dependent upon that tuberosity. And if it's fixed into place and it heals there, the patient typically does very well. Unfortunately, that doesn't always happen. And here's the same picture, or the same patient about 3 weeks later, and you can see that there's been a disastrous loss of fixation of the tuberosity fragment. So now it's pulled way up, and you can see that the humeral head now is sagged down inferiorly, and that this is a very unacceptable situation. This will not spontaneously correct because you've lost all pull of the rotator cuff, and it's completely detached from the shaft. And so this is a shoulder which is doomed to a poor functional outcome unless something is done. And you can see that the surgeon has cemented in the component. And so this is going to be a very difficult revision to either revise the tuberosity and put it back down, which is very difficult to do, or to replace the stem with a reverse prosthesis, which is the option we have now for dealing with these types of tuberosity and cuff issues, is the reverse prosthesis. And the reason it's so attractive is because we are not as dependent upon tuberosity healing with the reverse as we are with the hemi. If this happens with the hemiarthroplasty, it's basically a disaster. Whereas with the reverse, it's not nearly as bad, and the shoulder probably still does quite well, although not quite as well as if the tuberosities had healed. So this is another patient. This is one of my patients, and you can see here they have a very similar injury. There is a completely displaced humeral head fracture. It's lodged in the axilla. It's very high. There's no medial hinge. There's displacement at the calcar. You can be pretty confident that this humeral head will not survive. You can also see there's some significant comminution of the tuberosity. And we know from Jill Walsh's work that this means that the rate of healing of the tuberosity is going to be lower and not as efficient. So in my hands now in 2020, I find a reverse arthroplasty is probably the preferred treatment for this older patient. I think this patient was around 78, if I remember correctly. So here's the reverse. We have been able to get the tuberosities back down and suture them in place. Overall position looks quite good. If the tuberosities heal in a reverse, you probably get pretty good rotation. And that's been shown a number of times. If they don't heal, it's not such a disaster as it is in the hemiarthroplasty situation. Your shoulder will still move, you'll still have good flexion, but you just won't have as good rotation. So it's maybe not as good, but it's still better than what the alternative is. Well, that's my bias. Is there any evidence in the literature to support using a reverse? Well, there's a number of studies that are available now. And there is, this is one of them from about 2009. This is a while ago. It showed much superior flexion in the reverse and superior constant scores in the reverse group. So overall, the function after reverse in this kind of setting, and that's a bad proximal humeral fracture in an older patient, there seems to be some improvement in overall constant score and flexion in the reverses. Interestingly, rotation was still better in the hemiarthroplasty group. There is one randomized trial that supports this, backs this up, and would suggest that there is probably a role for reverse in this kind of setting. One thing that you may wish to do is to use a platform stem. If you have a younger patient, someone in their 60s or 65, we're reluctant to do reverses in that kind of patient because we know the longevity is really not optimal, and there may be some issues with how robust the prosthesis is. So for example, if I see a heavy 60-year-old man who likes to do hard work or works as a mechanic, and he has a bad forepart fracture, I would much rather use a hemiarthroplasty than a reverse in that patient because of the longevity issues, presuming that we get some kind of tuberosity healing. However, if you don't get tuberosity healing, then you have one of these platform stems in place, then I think that's an excellent way of dealing with this situation. So if the hemiarthroplasty tuberosities don't heal, then you can simply change to a reverse type prosthesis, not have to take the old stem out. And this kind of revision situation from a hemi to a reverse with a platform stem is usually quite simple if the stem is in the right position. That's obviously important proviso. Well, one of the groups in New York, and I think this was Dr. His name escapes me right now. Anyways, one of the groups in New York looked at this and found that they had 56 patients where they're going to convert a hemiarthroplasty to a reverse, and they found that if the stem was intact, it didn't take much time, it was quicker, there were less blood loss, and there were fewer complications and fewer revisions. So if possible, if you have a stem that you can retain, then that's a big advantage. Remember though, it's not always possible to retain a platform stem, especially if the stem is too high or the version is off, you may need to change it anyways. And here's an example of a platform stem. This is a total shoulder arthroplasty that's failed, complete failure of the rotator cuff, and you can see the humeral head is resting against the acromion, and this stem was solid and cemented. It was left in place. The glenosphere the glenoid base plate was inserted, glenosphere, and then it's a relatively straightforward and simple revision compared to what you have to do if the stem is intact, and that's a major benefit in this kind of setting. So I'm going to conclude this seminar by saying in 2020, these are the things I think that you can be sure of in the literature. Number one, most patients, especially the elderly, can and should be treated non-operatively. So the majority of patients for proximal humeral fracture should be treated non-operatively. If the fracture is badly displaced, if there's tuberosity malposition, if the humeral head is dislocated, these are the small percentage of patients who probably require some type of operative intervention. So we're very selective, especially in the elderly, as to who we intervene in, because the literature clearly does not support routine operative intervention for older patients with these fractures. We reserve it for healthy patients who have some kind of functional rehabilitation ability and who have badly displaced fractures, especially tuberosity displacement or shoulder dislocations. If you do choose to fix it, there are several well-established principles to maximize your success with the current locking plates. Make sure that you get a good reduction. Do not accept any varus malposition. And then try and place calcar screws to help reduce the risk of varus collapse. And lastly, in this regard, we do think the Phoenix plate made by ITS has some specific advantages in the ability to fix the tuberosities and control the head better than what's currently available. And we think this is proven biomechanically, makes sense clinically, and we're in the process of gathering clinical information to support our this plate. Lastly, in certain situations where the humeral head is obviously going to die and there's dislocation, we find that reverse shoulder arthroplasty is ideal in older patients or infirm patients, someone over 65 or 70, especially if they're low demand. In younger patients, it may still be wise to do a hemiarthroplasty with a tuberosity reconstruction, but to use a platform stem. So if that does fail, then you may change or revise it to a reverse with a minimal amount of perturbation for your patient. So with that, I will stop, and I'd like to thank you all very much for your attention and for the opportunity to present today.
Well, thank you very much, Professor McKee, for this nice talk, actually. And still, you know, regarding the open rejection internal fixation for the proximal humerus, like I remember, like we used a lot of plates. Remember that we used the T-shaped plate, the clover leaf, you know, the phallus plate. I think this, you know, the Phoenix plate is going to be like one of the marvelous plate. Actually, I showed it to you know, Professor Vitterji before, and he was asking, and we were asking, you know, about this plate. And I think it's a magnificent plate, like if we could bring it here. Yeah.
Yeah. Well, I mean, it's early days yet, but we think that has some real practical advantages compared to what is currently available. And so far, we've had very good success with the plate, and we have not had impingement. So it's good that way.
Okay, now we open the discussion. Now, Dr. Vitterji.
I have so many questions that will take the whole time. I will just divide my questions into, so we have it structured. First is the approach. Second is the age and comorbidities of the patients.
So
third is why not from the beginning? If you don't, you want the question one after one, or we can.
Well, maybe I'll deal with the first one. So
list.
Maybe I'll deal with the approach question first.
Let's do the yeah.
Okay.
You see,
so the tip.
I have a big debate in my department just let me elaborate about the approach, because we have in my department a big debate between the deltopectoral and the lateral approach. In my hand, the lateral approach is a direct approach. I have to take care of the neurovascular structures on the lateral edge, but it gives me a less muscle dissections, and it gives me direct to the tubercle, and I can reduce it simpler than the deltapectorant. So please, your opinion.
That's an excellent question. And that's probably the main debate right now in terms of approach. I will say this, for most fractures, I use a deltapectoral approach because it's easy for me to teach. And most people, once they get in the community, don't do this very often. So they need an approach that is simple and safe and reproducible for them. And for most orthopedic surgeons, the deltapectoral approach is probably the preferred. And if you look at the numbers, it is the preferred approach, especially if you don't do it very often. The downside is you're at the front of the shoulder. And often, as you point out, the pathology is at the back with the greater tuberosity. So you're kind of away from where you want to be. Most of the time, we have found that you can reduce the fractures fairly well. And once you have provisional fixation, when you gently internally rotate the shoulder, you can get to the back with the flange on the plate with the greater tuberosity. So in general, I use and teach a deltapectoral approach because it's simple and straightforward and safe. But I recognize that if you have a lot of posterior pathology, it's not ideal, and you may have difficulty there. We've also used the deltoid split or the lateral approach, and that is an excellent approach for dealing with the posterior pathology, especially of the greater tuberosity if it's pulled around the back, as it often is. The downside of that approach is that the axillary nerve is right there the whole time, and you need to be very aware of it and not to damage it. And if you damage the nerve and the deltoid muscle doesn't work, that can be disastrous for the patient, and especially if they ever have to have a reverse. For example, if the fracture doesn't heal. And also, if the fracture doesn't heal and you have to come back, revision cases, and I've done these, revision cases with a lateral approach can be difficult because the nerve is stuck in scar tissue. You're not sure where it is. And then you have to take the plate out, and then you can't usually put a prosthesis in from the lateral approach. So let's say you fix a fracture and it fixes it well, and the head dies and gets avascular necrosis. You have to come in back through a lateral approach, take the plate out, and then close that up, find the nerve, etc. Then go and do a deltapectoral to put your prosthesis in if that's what you're trying to do. And that's a hard operation in most people's hands. There is one randomized trial that I'm aware of. I think it's from Montreal, looking at deltoid split versus deltapectoral, looking at a bunch of fractures in experienced surgeons, and it really didn't show much difference between the two groups at the end of the day. So I think if you do a lot of them and you're good at it, the lateral approach is good. If you're only the occasional person there, probably deltapectoral is fine, and there's pros and cons each way.
All right.
Okay. If you allow me, Abdazar, to go to the next question.
Yes, sir. Go ahead. Yeah.
I'm talking now about the aging of the age of the patients. In Saudi, we have a big difficulties because most of these fractures, proximal humerus fractures, are not in the younger age. They are most of them above the 60s, and female with a lot of comorbidities and COPDs and so on. So in my hand, again, we are talking about discussion in the department, whether we go directly to the hemiarthroplasty, because we have to have a quick fixation. The patient can be mobilized directly. We don't get too much care about the mobility of the patient because most of these patients are, let's say, they have less activities than in Western countries. So what is your opinion in these terms? Because of the comorbidities, the aging of the patients, and the quick rehabilitations.
I think that the most important thing, I think, especially for young surgeons, remember, is that the majority of these fractures in the proximal humerus in the elderly can be treated non-operatively. So if you look, for example, in my old province of Ontario, we did a database search, and this is a province of 11 million people, and everyone has a unique number. Of 30,000 humeral fractures that we identified over a 5-year period, 25,000 were treated non-operatively. So 25 out of 30 were treated non-operatively. And those 25,000 people had a very, very low rate of ever requiring anything else to be done. So a few had arthroplasties down the road, et cetera. But the vast majority of patients were treated non-operatively. This is elderly patients and did quite well. Of the patients who do require fixation, where there's unacceptable displacement of the tuberosity and or dislocation of the head or neck, if they have, if they're low demand and elderly, and especially if there's dislocation of the head or factors that would affect the survival of the humeral head, and in my hands, a reverse total shoulder arthroplasty is the treatment of choice for most of those patients. It's fairly a good operation. It will last 10, 15 years in most people. For someone 70 years of age or older, I think that's a good operation. If the bone quality looks reasonable and the person's more active, then you can use fixation. And that would be my second choice in most of these patients. The hemiarthroplasty I reserve for the younger patient with a fracture that's not reconstructible, and where I have a 60-year-old, as I mentioned, who's very active and works as a mechanic, but I can't save or salvage the head. That would be a patient I would do a hemiarthroplasty on, but I'd want to make sure it was in a platform stem.
Maybe we
okay.
leave the Abdulzahab, you can allow somebody else to ask. I don't want to take all the questions.
You have Dr. Qazi
Yes.
Manzoor.
Dr. Manzoor, yeah?
Professor, thank you very much for making such a complicated subject so easy for us and giving it the end summary of the whole thing. I was just wondering, using classical stabilized locking plates, not the Phoenix type, as you rightly said, inherently there are biomechanical problems that give complications. We used to add cerclages usually, fiber cerclages, either for the trochanter or for the neck or the dislocation. What do you think about using those cerclages with Phoenix or without Phoenix? Because we have no experience of Phoenix plate.
So the one biomechanical study I showed, and I do that too, so I'm not trying to say it's not good, but the biomechanics are if you put cerclage suture or cable through the cuff, then into the tuberosity and then into the plate, and biomechanically it does not make a big difference. It doesn't help your stability of your tuberosity. And additionally, I've done that clinically, been very happy with repair, and yet still seen the tuberosity pull off, as I showed in a couple cases. So I think it's a good idea, but I'm not sure that it works, unfortunately. And that's why we designed the plates. We have better fixation with actual plate rather than trying to suture something to the plate. As you know from doing it, you do it and I do it, but often it's not very satisfying with the stability that you get. And a lot of these studies that we spoke of, the surgeon did that as well, and yet still it was difficult to show a routine improvement in function relative to non-operative care.
Thank you.
Yeah, sir, I have a question myself, regarding, the 4 parts of humerus fracture, you remember before we used to do the hemiarthroplasty, the large head, that was in Toronto like a long time ago, until now actually. But, to be honest with you, we're not getting that great result, and still the shoulder abduction is not that great. And I think, from now on, we should start, also Professor Khalid Batarji now, he's pushing us to use, the reverse shoulder. And I think, reverse shoulder, I've seen a lot of cases, like from my colleagues, because it usually depends on the deltoid, isn't it?
Yeah, so if you're going to do a reverse, that's fine. And that is becoming a very popular technique, but you have to remember, you are extremely dependent upon the deltoid, especially the anterior deltoid. And if you don't have a deltoid, if it's paralyzed or it didn't work or you injured or whatever, and you put a reverse in, the shoulder won't move. And there's also a very high rate of instability or dislocation of the shoulder. You have to have that deltoid tone and muscle function to make a reverse arthroplasty work.
What about, sir, of the deltoid inhibition? Some of the patients were doing like, the fixation or open reduction internal fixation, or, the hemiarthroplasty. So they're getting the deltoid inhibition, the weakness of the deltoid. Like this is it like neuropraxia or like?
Well, no one knows for sure. And if you look at the axillary nerve in these cases, there's a lot of neuropraxia that's under-recognized. So an actual true and complete axillary nerve palsy clinically is quite rare, but a lot of patients, if you do EMG nerve conduction tests, have a partial palsy or some abnormality with the nerve. So that may contribute to it. If you see it on the x-ray, what I think one of the best things is to teach the patient some deltoid exercises so they start contracting the deltoid on a regular basis. And there's some sheets that the physiotherapist can give them to help get that muscle tone back and to start using the arm. So when you see that inferior sag, the solution is not to stop motion, but to increase it. So you don't immobilize the patient, you get them moving their arm around more. And the more they use it, the more deltoid tone they get, then the better that inferior subluxation will be. So the key thing there is early motion and have the stability with your fixation to allow early motion.
All right. So if you have more questions, please, Dr.
Do you have participants' questions, Dr. Yasser?
We have one question from Dr. Ala Barakati. He's asking when you are going for arthroplasty, is there any role to assess the rotator cuff prior to choose the prosthesis using MRI, whether to choose hemi or reverse?
Yes, that's a good question. So if you have a fracture or fracture fixation and it hasn't worked out and you're going to do an arthroplasty, one of the main things you'd like to know is what's the straight and function of the rotator cuff. So for example, if you look at your x-ray and you can see that the greater tuberosity is pulled off medially or pulled off, then functionally that's the equivalent of having a large rotator cuff tear. So if you have significant malunion or malposition of your tuberosity, then a hemiarthroplasty is a tough operation with poor results. And Jill Walsh showed that if you try and mobilize the tuberosity and put it back, it can be very difficult to do, and the results aren't great. So first of all, if you see the tuberosity, that's a good sign of what's happened to your rotator cuff. So if it's around the back or up over the top, you know the cuff is probably not working. If the tuberosity is in the right spot and you don't know about the cuff, then on some occasions, an MRI might help you. But the problem there is that there's a lot of artifact or scatter or disorganization from the original fracture. So often it's just a matter of doing the operation and being prepared to do either in that kind of setting. In general, most patients who have failure fixation of the proximal humerus now are better off with a reverse than a hemi unless they're very young. And if they're young, the tuberosity is in the right spot, and you see the cuff intraoperatively and it's a good position, then a hemi is probably a good idea.
So that means that the decision is an intraoperative decision?
I would say most of the time I'm making that decision preoperatively based on where the tuberosity ended up, which is usually in a bad spot. And that's why you're often revising these after failed fixation, is because there's malposition of the tuberosity and dysfunction of the cuff. So if that's the case, preoperatively, I know I'm going to reverse. In the more rare situation where the tuberosities are in the right position and an MRI is not helpful, then I would make the decision intraoperatively in that kind of setting, yes. But it's rare.
Yeah.
Okay, Prof. Regarding, hello? Yeah, regarding, the greater tuberosities now, we're getting a lot of cases for avulsion of greater tuberosity fracture, and I believe strongly that putting a screw only does not hold with that fracture, and suture anchors does not play any role. Well, till the time that we're going to get the Phoenix, I strongly believe in the Phoenix, plate. So what do you think we're going to do, like plate or just? So what's the best solution for the tuberosity there?
You mean isolated greater tuberosity fracture?
Yes, yes,
Yeah.
sir. Yeah.
So we have a design for a plate that would deal with that. We just haven't made it yet. I think probably the whole entire Phoenix plate is a bit too bulky to put on just for a greater tuberosity fracture. So there is a design for a smaller plate, but we haven't made it yet. So in that setting, I agree with you that a single screw often is not very satisfying, doesn't give a very good bite. Suture anchors are too small. Often I'll do drill holes through bone to help augment that. And I did a case like that the other day. So I used a large suture, such as number 2 or number 5 ethibond with drill holes right through bone, like 4 or 5 sutures like that. That's often good enough. And then they get put in a splint post-operatively. If the piece of bone is big enough, then just taking a small plate, like you saw on a couple of the slides there, a 1/3 tubular plate, cutting it off, and then bending the hooks around it and then putting that in, that is a very effective way of dealing with that kind of fracture in my hands.
Like a 1/3 tubular plate, probably, right?
Correct.
The 1/3 tubular plate, remember, and hook it up there.
Yeah,
And, just,
and then you cut it and you take the cut end and you make
The
it into two hooks and you embed it right into the cuff. Yes.
All right. Okay.
Yeah.
So
I think we are on time.
all right. Thank you, Professor McKee, and and thanks for the attendance. Thanks for everybody. Thanks for Dr. Khalid Batarji. And
Thank you.
well, anything more do you want to add, Prof?
No, I think that I would be very interested in having some of the Saudi surgeons use this plate. I think that you have good experience, good technique, and a lot of patients who would benefit from it. And I would be very interested to hear what you thought of it when you use it, the good and the bad. It would be very useful for us to know that. So hopefully we can get that plate to you.
And also, Dr. Khalid Batarji, our professor here, if you want to say something, a good word, please, Prof.
As I told you from the beginning, we are still interested to use this plate. So let's have the company contact us and then we can go from there on, please. Okay.
We will do that. Thank you.
Okay.
Okay.
Thank you.
Thank you very much.
Professor McKee. Thank you, everybody. Have a nice evening.
Thank you very much for the invitation. It's been great chatting, and thanks, Sati.
Thank you. Thank
All
you.
right.
Yeah,
Thank
good
you.
day.
Thank you.
Have a good day. Thank you.
Good night.
Good night.
Thank you,
Thank
Manzoor.
you.
Thank you.